Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us learn how to care and approach patients living with HIV. This session will be given by Dr. Jejunee Rivera, an infectious diseases graduate from the University of Santo Tomas Hospital, who is now currently practicing in Zamboanga. This session will be moderated by Dr. Erica Pineda.
Good morning. The notoriously bad clinical and psychosocial reputation of AIDS makes caring for people living with HIV, or the PLHIV, complicated. The health worker in you also doubt the capacity of the critically ill PLHIV to recover. We are challenged with their complicated conditions. Many of them, having insight into their moribund condition, get depressed or are in denial, or both. Given these circumstances, we also ask ourselves how to communicate with a patient whose defenses are way up above his head. Halos hindi mo na nga siya makita. Our thoughts and feelings are in sync with our patients, because whether we like it or not, we naturally bond with our patients, being humans ourselves. But we have to care for them the way God cares for all of us. For my disclosure, I had a negative HIV screen test 3 months ago. But then again, by virtue of my good looks, I cannot guarantee the same today. Also, please be warned that this presentation may contain lewd and explicit materials. Parental guidance is a must. For our objectives this session, number 1, to show the need for paradigm shift in health workers' understanding of the natural history of HIV. 2, to explain why health workers need to contribute significantly to stigma reduction by demonstrating non-threatening communication with their PLHIV and their significant others. And number 3, to present the local HIV care book, linking patients to care, provision of highly active antiretroviral therapy, and relevant services. Let us begin with a case of a 25-year-old married man from Bongao, Tawi-Tawi, that is the tip of the Philippines in the south. He presents with unproductive cough, fever, and progressive dyspnea in the last 7 days or so. He thinks he has COVID-19 infection and is ready for a swab test. However, he also disclosed that he had been having on and off fever and cough for the past few months. He also had no previous admissions nor surgeries. He speaks in phrases with effort, and supraclavicular retractions were peeking through the collar opening of his oversized shirt. He is also bothered by the whitish cover over his tongue. He thinks he might have abused Texetidine mouthwash. He says he also read from the internet that his condition has some similarities with some manifestations of AIDS. But he quickly tells you that he never was diagnosed for other medical condition in the past. He does not smoke. He occasionally drinks during private parties where he has observed some of his friends take drugs in what they call party and play. However, he says he had no participation in those illegal activities. While COVID-19 is a strong consideration here, TB and PCP cannot be ruled out because of the chronicity of the respiratory symptoms. And alongside oral thrush, HIV infection should be within your radar. If this were HIV or other infection with COVID-19, it could not have come from blood transfusion or injecting drug use, although you still doubt the latter. Let us set aside COVID for now because he is ready for the RT-PCR anyways. What other questions will you ask your patient? So you thought of the two other possible causes of HIV transmission: mother-to-child transmission and unprotected sex. You carefully start with what you think is the least stigmatizing question. How's your mother? Then you realize that the question was irrelevant because if he got it from his mother, he must have given you a colorful past medical history of his childhood when treatment of HIV in the country, especially in Tawi-Tawi, was not yet available. So you proceed with sexual history. Have you had sex with other females or males in the past? You emphasize past because past is less threatening. It gives him the chance to claim that he is a changed man now. But you pursue. Have you had insertive oral sex, receptive oral sex, insertive anal sex, receptive anal sex? Then he shyly but honestly tells you, I am Versa, doc. Versa. My students in the medical school ask me what Versa is. Some of them know it. I tell them that is simple. It's like I poke you, you poke me, then we get upward rolling of eyeballs and ecstatic convulsive spasms. Sometimes it comes with salivation, parang may sanib lang. Then you continue with history of injecting drug use because you doubted it. Okay. Previous alcohol use, present alcohol use, previous use of recreational drugs such as marijuana. It's a pity that millennials do not know marijuana today. Ever used shabu? Ever injected drugs? Ever injected drugs from used needles? Very thorough and precise questions like those you see in a research questionnaire. But what do you think is your patient feeling? Sa isip niya, patay. Baka ipapatukhang pa yata ako nito. So he denied drug use and asked, Doc, sa tingin mo ba AIDS talaga ito? Before you answer, let us examine what we have in our collective mind so that we can answer the question in a manner that will be helpful for the patient. Stigma and discrimination has always been a lingering fear in the general population, and most especially so among people who know they have a need for HIV testing because they have exposure. This is the very reason why many still get tested very late, only when they become symptomatic. Since 2013, Thailand has been a part of a global effort to measure stigma and discrimination in the healthcare facilities. This is being done so that strategies can be incorporated into their health programming. Let us examine their findings. At least umaamin sila. May insight sila na maaring nga na ang attitude nila ay hindi discriminating sa mga PLHIV. And to think, Thailand has a very permissive culture. Sex is really considered as a usual, casual activity of daily living. Hindi sila gaya sa atin na nasa loob ang kulo. Please pardon the term. These are the findings. 31 to 40% assume PLHIV do not care if they infect others. 37 to 49% of their health workers feel PLHIV should be shamed of their status. 65 to 70% of those health workers think PLHIV got infected because of immoral or irresponsible behavior. I remember that I was really thinking along this kind of feelings before. 54 to 59% believe women with HIV should not have children. 32 to 41% fear touching PL-HIV belongings. 58 to 63% fear dressing wounds of PL-HIV. 61 to 66% fear drawing blood from PL-HIV. 34 to 42% wear double gloves when dealing with PL-HIV. And 38 to 47% take any special precaution with PL-HIV, but not with other patients. In other words, around 90% admitted to at least one stigmatizing attitude sa kanila. In the Philippines, I don't think we have done this research yet. Let me show you this case series from Zamboanga City Medical Center way back in 2004. It demonstrates that stigma kills. People living with HIV were diagnosed late because they did not undergo testing before when they were well. They came to the hospital only when they were really sick. Half or about 50% of our admissions ended up with deaths. Healthcare for the PL-HIV does not have to resort to death. Our experience in CCMC reveals that an MSM who is a PL-HIV who gets diagnosed late and before gets delayed medical attention loses an average of 33 years of potential life. And he loses not only life, but potentially productive life as he dies at the prime of his economic productivity when he is 32 years old. This means that preventable deaths from HIV infection are not addressed. The potential life loss to HIV presents an issue to the economic productivity of the affected families, the community, and the country. An elegant article by Cecil Balgos, published by the Philippine Center for Investigative Journalism, is a discourse on HIV entitled Drugs, Death, and Disease, Reporting on AIDS in Southeast Asia. It reflects how the progression of the biomedical events in AIDS is uniformly extended to mere HIV infection. And it further deconstructs the fact that people living with HIV are portrayed as culprits, people with nothing in their heart and soul but orgy and depravity. Now, what do we remember about HIV/AIDS? Philadelphia, the movie that starred Tom Hanks, depicts HIV discrimination. The underlying story is about a gay man with HIV at a time when medical management of HIV seemed hopeless. Back then in the movie, we did not have antiretroviral therapy in the Philippines. Although the movie was filmed at the time when PL-HIV already started taking ARVs, the experience that lingered in the minds of the artists who created the film was the violent medical course of the gay men who slowly and painfully died of AIDS complications. Why is this? What kind of values did this film project about our society? Until today, the stigma and discrimination in the movie continues to be a reality to many of us. But this was the reality in the 1980s. It is now 2021 and HIV is curable. I am sure that all of you are familiar with this old slide. This natural history of HIV infection is showing that after one gets an infection, a person may be honeymooning with the virus for a time. Then for a while, the virus takes hold of the immune system, abolish the CD4 T lymphocytes, then one gets multiple opportunistic infections and dies. So when we tell our patients this, they remember that they will die because we make it appear that this is the natural course of the disease. Will this story bring them wellness, or is this terrorism? If it does not bring wellness to our patients, then it is the latter. Does that make us any different from terrorists in YouTube who decapitate people alive? So we tell our 25-year-old male patient about the natural history. Should we? Of course we can, but it is best to focus on 2021 facts, not 1980 facts. And what are 2021 facts? Stable immune function can be achieved by antiretrovirals. Viral load can become undetectable below the limit of detection. HIV becomes untransmissible. Your immune system can recover to protect you against opportunistic infections. Normal life is the rule with HIV infection when one is on ARVs. And that is why I am saying there is cure for HIV. Virtual cure. May I repeat? So, shall we tell our 25-year-old male patient about the natural history of HIV? Sure, we can. But it is best to focus on 2021 facts, not 1980 facts. So we tell our patient that stable immune function can be achieved by ARVs. Viral load can become undetectable and HIV becomes untransmissible. Your immune system can recover to protect you against opportunistic infections. And normal life is the rule with HIV infection when one is on ARVs. There is cure for HIV, virtual cure. Today, we have highly active antiretroviral drugs. What other good news do we tell our patients? These drugs are available for free in the treatment hubs all over the country. These drugs miraculously make you look younger. It will restore your health. One pill a day and you're okay. HIV infection is very easy to treat. Mas nakakatakot pa nga ang diabetes at high blood. Di hamak na mas komplikado rin ang gamutan sa asthma at COPD. Sa HIV, walang bulahan ang gamutan. One pill a day and you're okay. There is cure. There is virtual cure. Please reassure your patients that there is cure. There is virtual cure. That is what they want to hear, not the horror stories. The horror stories crush hope. As doctors, we are called to be healers, not punishers. Our communication has to be consistent with this calling to heal. The self-image of the PLHIV in Zamboanga City, according to Besares, is nowhere different from yours and mine. They aspire for better health like we all do. They are willing to work and be employed so they can support not only themselves but also the children of their siblings. Some of them want to pursue a business or tend to a farm. And many PLHIV desire to reach out to other PLHIV and help them as well. The PLHIV's dreams and aspirations resonate ours. In other words, we are called to look beyond the desaturation, the infiltrates, and the acidosis when we care for the PLHIV with respiratory distress. A patient-centered care comes from a healer that gently palpates his patient's sense of humanity. And only then can we provide a truly supportive environment for the PLHIV. When alone with your patient, avoid scary queries. Most of our patients need to be reminded of risks of HIV transmission because they have already seen that on the internet. So, we just simplify the language. Wala na yung mga nakakatakot na questions that we have posed earlier. We simplify our language. It is also best to reassure the patient that utmost confidentiality will be observed. Tayo lang makakaalam ng kwento mo. Hindi na kailangan malaman ng iba. Di ba alam natin kung paano nahahawa ang isang tao ng HIV? Sa tingin mo ba may nangyari sa iyong ganito in the past? Pag sumagot affirmatively, I tell them, okay po, magpapatest lang tayo. I will be happy pag negative ang result. Pero ikaw lang talaga ang makakaalam ng result. Pero kung gusto mong i-share sa akin ang result mo, andito lang ako para tulungan ka. Hindi malalaman ninyo man ang result. Ikaw lang din ang kakausapin ko tungkol dito. What is the reality now? This graph is 12 years old. Nagbibinata na ang graph na ito. Please take heart. As health workers begin to provide correct information on HIV, more people living with HIV access healthcare and live productive and happier lives. Is it not our calling to share God's love to everyone? What kind of information about HIV/AIDS shall we share? Over 12 years ago, over 92% of people around the world think that HIV is an important epidemic. Ngayon, lahat na siguro naniniwala. And our response to this as health workers is to inform people around us that treating HIV is not as difficult as they imagine it to be. This is the paradigm shift. We tell people that the late stages of the natural history of the disease is even reversible with treatment, and that AIDS is nearly extinct like a dinosaur. The care continuum for HIV begins with diagnosis, but this is where the hardest challenge is. Without provision of appropriate psychosocial support, patients may be easily lost to follow-up, and they end up not linked to care. Linking to care means providing a patient options for access to antiretroviral drugs and treatment of opportunistic infections. As much as we want to promptly treat HIV-related diseases and prevent the same, some of our patients may not be comfortable with the nearest HIV treatment clinic. Stigma is real even among health workers. So, provide patients options for care in multidisciplinary clinics where confidentiality equals anonymity. Please do not take it against your patient if they opt to see another doctor elsewhere. Baka kasi sister-in-law niya ang sekretary mo or kabit ng neighbor nila ang triage nurse ng ospital niyo. Please respect their fears as well. Reassure them that you respect their privacy as much. Once they are retained in care and are taking ARVs, control of HIV infection and viral suppression is easily attained. Then, patient's immune status may be well restored. With this, immune competence may be achieved for as long as the PLHIV cooperates with treatment. I tend to tell my patients that their role is to cooperate with treatment and to be happy because they will live a normal life forward. Where do we send our patients? This is a list of DOH-designated HIV treatment hubs and primary care facilities in the country, updated by WHO as of July 2019. So pwede lang talagang ma-search ito sa internet. Zamboanga City is on page 2, along with two other relatively newly established treatment hubs in Dipolog City in Zamboanga del Norte, and another in the remote rural Margos sa Tubig in Zamboanga del Sur. But please do not be surprised that some of the patients from Zamboanga Peninsula still go to Zamboanga City for treatment to maintain anonymity in their communities. Many patients from Zamboanga City as well have actually relocated to Manila for the same reasons. Please respect and support their decisions. Then try to link them to care. Refer them to a treatment hub where they can go. Our diagnostic algorithm for HIV is also changing. Confirmatory test for Western blot used to be the norm, but this takes 7 to 21 days for confirmation. So this gives a lot of psychological stress for patients and health workers. Patients commonly experience waiting for what seems to be like a death sentence. Health workers are also afraid that patients will not come back. The Rapid HIV Diagnostic Algorithm, or the RIVDA, use three different rapid tests to confirm HIV infection. This is advocated by the WHO. The first test has the highest sensitivity so that no one is missed. The last test has the highest specificity so that true negatives are also identified. According to TELAN, the RIVDA shown on the right box performs better than the old conventional algorithm on the left box. As shown earlier, the RIVDA has the potential to provide the result on the same day and in fact within hours. Then patients can be immediately linked to care, including mental health care, to ensure that they are started on their ARVs as warranted. Caring for the PLHIV demands appropriate education and information as mandated in these sections and subsequent sections of Article 2 of the Republic Act 11166, otherwise known as the Philippine HIV and AIDS Policy Act. The first step towards this is to ensure that health workers catch the appropriate education and information that will contribute to the well-being of the PLHIV. This means that health workers have the moral and legal obligation to ensure a culture and gender-sensitive education and information intended to provide a better sense of well-being for the PLHIV. The Republic Act also stipulates that PhilHealth shall provide financial coverage for patients as well as outpatient HIV care. This is specified in Article 5 of the country's HIV Aids Policy Act. So meron silang inpatient care, meron ding outpatient care package from PhilHealth. Section 33 of Article 5 of the same Republic Act also specifies that the country's health department shall provide free and accessible antiretroviral or ART and medication for opportunistic infections to all PHLIV. Management of PLHIV shall also be outlined in a manual created by DOH, and that is already existing. Now, this is the new phase of ARV in the country. It is called the TLD, and that stands for tenofovir, lamivudine, and dolutegravir. This pill, taken once daily, contains tenofovir, lamivudine, and dolutegravir, as I have said. Dolutegravir is now the backbone of the treatment of HIV because it is tolerated well by most patients and has high resistance barrier, meaning it has an excellent safety profile, and even when HIV has resistance to the other drugs of its class, dolutegravir seems to overcome such resistance and is able to suppress viral multiplication. In fact, even when the virus has resistance to both tenofovir and lamivudine in the combination pill, dolutegravir still seems to perform well in suppressing viral multiplication. In other words, maganda itong dolutegravir. It is mathematically competent by itself. Who is eligible for treatment? Okay. Those initiating patients, existing first-line patients on tenofovir, lamivudine, and efavirenz, but experiencing side effects, and second-line patients who are on AZT and abacavir-based regimens. In other words, TLD is for most adolescents and adult patients. These are the more common adverse events with dolutegravir, no? Nausea, rash, insomnia, headache, and weight gain. We also see this with other drugs. All these are manageable. Rare but serious side effects that may warrant discontinuation of the drug are the following: hepatotoxicity, hypersensitivity, and myopathy. This bar graph by Batista shows how very few patients experience side effects of dolutegravir. So let us go back to our 25-year-old patient who presented with cough, fever, and progressive dyspnea. His SARS-CoV-2 RT-PCR turned out to be negative. Sputum AFB turned out +1. Gomori, methenamine silver stain, revealed deflated tennis balls and crescents likely from Pneumocystis jirovecii. What will you tell your patient? Of course, I will tell them the test results. Then I will add, you will be on medications that will not only treat your infections, but will restore your youth as well. Mamumukhang bata ka uli. I will envy you just like most of my patients. Oh. Because in fact, this is a very common observation among our patients who are on ARV. We are not sure about the mechanism kung bakit talaga sila mukhang bumabata lalo. Mas bata pa dun sa kanilang previous pre-morbid conditions. We know that HIV accelerates aging. Pero talagang iba yung pagiging bata nila when they are on medications. So we reinforce this among them, that treatment will restore their youth. That is what they like to hear. Finally, allow me to leave you with this slide because it captures all that I had to say today and ever when I talk about HIV. When dealing with the PLHIV, embrace, not abandon, because that is the time when they need it the most. As Christ said, love your neighbors as I have loved you. Stay safe, everyone, and thank you so much for your attention.
For the highlight of this postgraduate course, let us be inspired as we hear from Dr. Bong Javier. Please proceed to www.tiktok2021.com and click on the Distinguished Alumnus Lecture in the Plenary Session tab.